Today, I'm going to talk about the general state of affairs of cancer survivorship in the United States. If you have questions, you can put them in the chat if you'd like, or you can go ahead and wait until the end when we'll have a Q&A. And if you put something in the chat, Jacinta will just give me a heads up when I'm done speaking. Next slide, please. So this is when I talk about the scope of cancer survivorship in the United States, core values of patient-centered care that have guided survivorship care, initial efforts to address the survivorship issues with instituting a survivorship care plan by the Commission on Cancer, development of a hospital-based cancer survivorship care delivery models. There are many models of care. The recent developments in transition models to primary care, which is trying to get survivors back into the community for their care, and the review of I'm going to talk a little bit about some of the evidence-based interventions and then recommendations for the future. Next slide. So the definition of survivorship has evolved. And so I'm looking here at a slide from ASCO, American Society of Community Oncology, and it is originally survivorship started at the end of your treatment when you are free of disease. That model of care is not really how we're thinking of it now. Recently, in the last several years, the National Cancer Institute has changed our definition of survivor from the moment of diagnosis until the end of care and death. So it really does cover the entire continuum. As you can see with the arrows here, we had originally, it started at the end, but now it starts at the beginning and the end of life. Next slide. The population of survivors is increasing exponentially. It really has gone from about 8 million at this point. Actually, it's a little bit more this year because that's a slide from last year ago. And now it's about 8.1 million, I think, survivors, and then 26 million survivors by 2040. So you can see it's increasing at an exponential rate. Next slide. Now, why is that? There are some great reasons why. Survivors are living longer. Treatments are more effective. We are better at getting people into a no evidence of disease phase, so they are in survivorship for a longer period of time. So generally, the number of people in the blue is male and the orange is female and the gray is everybody. You can see that the people living more than 3 years is really high. And then as you get further out, it's still increasing with a percentage of people living beyond 25 years. So people are living much longer, and it's increasing by 33% in the next decade. So we're just going to have a lot more people surviving more than 5 years. Next slide. Another factor that we're pretty much all aware of is that older adults are the fastest growing subgroups in the cancer population and in general. As we know, the boomers are aging, and we are having more and more people that are in the 65 or older range. 64% of survivors now are 65 years of age or older, and in the next decade, the number of people in this age range is expected to double to 67% of new cancer cases, and reaching levels of 14 million people worldwide being 65 or older. It is estimated by 2040, 73%, like 2/3 of cancer survivors will be 65 years or older. And this is not just from treatments being more effective. It's really from screening, advances in screening, treatment, as I mentioned, and supportive care, which have looked at improved cancer outcomes significantly. And so older adult population is increasing. Next slide. So survivors are at risk for recurrence in second primary cancers. Occurrence increases as people age. So, of course, as people are living longer with cancer, we're just seeing people with more side effects from treatment, risk for recurrent and second primaries. The incidence of second cancers at 30 years from primary diagnosis depends, obviously, on the type of cancer you have, but it's about a quarter. And these are early stage people. So a second cancer would be if you're in early stage, you haven't had metastatic disease and you're living for longer periods of time. So it is 21% for breast cancer, about 18% for colon cancer, 27% for bladder cancer. These are people living 30 years from primary cancer diagnosis, so a long time, and getting a second cancer. The risks are associated with things that they're risk for cancer in general. So things that will increase a survivor's risk are tobacco, alcohol, hormonal influences. We're still in a bit of a debate about that. HPV, genetic predisposition, and treatment causing secondary cancers. Risk is higher among children and young adults, which I'll get to in a moment, because people live longer and the treatments are very invasive. So related to that, aggressive cancer treatments like a transplant, high-dose chemotherapy, high-dose radiotherapy to the chest wall and lymph nodes, they can really increase people's risk for esophageal, bone, soft tissue, and lung cancers. Next slide. But cancer isn't their only medical problem. So we originally thought that people with cancer were at higher risk for comorbid problems like heart disease or kidney disease, in terms of mental illness, things that happen later. What the studies have recently found is that the risk for comorbid conditions other than osteoarthritis are not significantly different between survivors and the general population. That's the good news. So it's not really true that they're more likely, it's just that they're having their comorbid problem in the presence of cancer, which is yet another problem. Next slide. Many survivors, and this is the focus of a lot of my work, have unmet care needs. So obviously they depend on tumor type, but across the every type of cancer, fear of recurrence is the biggest psychosocial issue that people experience. Highest in breast cancer survivors, but it is a very, very, very high issue, a very significant issue in this population. Breast cancer survivors do report more unmet needs, but most of them have to do with psychosocial needs. Head and neck survivors carry large symptom burden, so you can see that the nature of longer-term survivors' issues are related to the type of treatment they're getting. Prostate cancer, as we probably all know, have sexual and bowel concerns, so that would be their primary. And colorectal survivors, of course, have bowel function issues and fatigue as some of their treatment side effects. So it does vary by the type of cancer that you have in the treatment. Next slide. I'd like to bring up the issue of adolescent and young adults because cancer is becoming more common. I think we're all aware that colon cancer guidelines have been decreased to age 50 because of the incidence really increasing of cancer at an early age before 40. Adolescents and young adults are 15 to 39 years at the time of diagnosis, and there's about 90,000 people being diagnosed, but they're raising about 0.3% per year with breast cancer and thyroid cancer surprisingly being larger populations. Next slide. They have a longer survivorship period and more unique needs. Obviously, the treatment at a young age is going to put people at risk for secondary cancers, cardiovascular risk, diabetes, fertility, neurocognitive effects. But the psychosocial effects are huge. Rates of depression and suicide ideation are greater in adolescent and young adult survivors. Social disruption during important periods where people are meeting their partner, starting a family, and starting a career. And there are known financial and employment concerns in this population. So while there might not be a huge population, it's growing. And the burden that these people experience is greater. Next slide. So I'm going to move to the second topic, which is the core value guiding survivorship care. And I think this is a medical value anyway, but I thought it's worth going through it just because I think that sometimes it gets forgotten, especially in survivorship and how initially it was approached. So of course, the Iowa Institute of Medicine said providing respectful, responsive care that is tailored to preferences, needs, and values, and ensuring that values guide clinical decisions. The common elements are, of course, the quality of the care being given, focusing less on physician authority over care, on fostering partnerships and compassion and collaboration between provider and system and patient and care provision. And the reason I'm saying this is where the approach to survivorship initially went wrong, and empowering patients to take an active role in their care and fostering really high quality care. Next slide. There's 8 principles. And again, I'm pretty sure you all would look at them and say, oh, these are, this is guiding all care. But it is important to keep in mind when we're talking about transitions to survivorship and long-term survivorship, respecting values, preferences, and needs, coordinating and integrating care to alleviate vulnerability. So coordinating clinical care and coordinating with support services, providing information and education to survivors and the processes of care, how to facilitate their autonomy once treatment is over, and maintaining their cancer-focused care and getting back to their other medical care, enhancing physical comfort. Next slide. Providing emotional support to alleviate fear and anxiety, involving family and friends in care, providing continuity and transition. Another thing to keep in mind when I go to the next section about continuity of care and transitions off of survivorship, and providing access to care. Again, another issue that has been of some concern is care when it's needed, location of hospitals and clinics being somewhere accessible, and availability of transportation. And is someone not hearing me? Do I need to speak up?
You sound fine, Dr. Manning. I think
Okay.
Jane is just having trouble. She'll sign back out and then come back in.
Okay, I'm just going to get closer to the camera because it has been an issue that I have had before. So I'm sorry. Next
No
slide.
problem. Thank you.
I'm seeing the bottom, so I'm seeing some of it. Next slide. So this, oh, sorry, go back. So patient-centered goals for survivors, as I've alluded to, are to educate the survivor and family about the care that the person received and recommended post-treatment cancer care, the diagnosis, treatment, symptoms, the risks for recurrence, late medical effects to expand and how to manage them, recommended surveillance for their current cancer and other cancers that they are either at risk for or as a person in their age range, to keep them apprised of the guidelines, and common psychosocial effects. And as I said, psychosocial effects are ubiquitously an issue in survivorship. Even if people know everything about risk for recurrence being low, it's not always a predictor of how the person's going to respond psychologically to the cancer diagnosis. And many of these symptoms come on when they're done with treatment, because treatment is a security that they're having something being treated. The next goes assist the survivor in taking an active role in managing their cancer survivorship care, to help the survivorship and the oncologist coordinate care with their primary care providers and other specialty providers that they'll be having contact with, such as cardiologists and endocrine, because many of the treatments will have cardiovascular effects, especially involving radiation to the chest. And then fostering access to survivorship care, providing care tailored to the needs of the survivor, and foster engagement in a healthy lifestyle. So not only taking care of the surveillance that they need for their cancer, but really doing things that will, for everyone, reduce risk, losing weight, maintaining a healthy diet, reducing intake of red meat, and other healthy behaviors that sometimes are associated with getting cancer in the first place, stopping smoking. So there are things that survivorship should be focusing on that are different than what happened during their treatment, which was completely to focus on the cancer. So the overall goal of a patient-centered care would be to reduce care fragmentation. And as you know, our medical care system is highly fragmented, and survivors experience the same thing. They go to their oncology care provider and they think, I can stay there to get all of their care, but they can't get all of their care there. It needs to transfer back. So cardiovascular risk, other risk factors, need to go back to the primary care providers, deliver a high quality survivorship care, minimize symptom burden, and achieve better outcomes, both psychologically and physically. Next slide. So what happened? In about 2005, there was an IOM report that was done with input from stakeholders, the National Research Council, and these guidelines were called From Patient to Cancer Survivor, Lost in Transition. And it was really a wonderful document that talked about what we should be doing for patients who have finished definitive treatment, meaning curative treatment. The guidelines that they came up with was to have a standard of care for all cancer programs, to develop and implement a process to monitor the dissemination of a survivorship care plan as part of the standard of patients with cancer care for patients with cancer. So it should be monitored by the Cancer Committee called the Commission on Cancer, and there were requirements including what the treatment was, what the recommended surveillance is, and anything that has to do with follow-up care. and the standards of care. So this was supposed to be both handed to and electronically provided to patients, and then also to the care provider in the community. So this was a starting point for the Commission on Cancer's involvement in survivorship. So where have we gone in the last 18 years? Next slide. So here's the accreditation, and just going over it again, these were the kinds of things that needed to be in the survivorship care plan. And it was adopted by American Society of Clinical Oncology. Sorry, I said community before, but it's clinical oncology. And it was supposed to be delivered across cancer centers, even community centers. Next slide. So what happened? I did have a bunch of slides that I did delete here. So the research suggested that there were significant implementation issues. So initially they said, oh, half of cancer centers should be giving these out, and you need to keep track of it, and you need to keep track if it was delivered, and you need to keep track of whether it was disseminated to the provider outside of the oncology centers. But unfortunately, what happened was that while they may have produced them, well, in fact, they probably weren't producing them, but about 12 to 43% reported not getting a survivorship care plan. So about half of patients reported not getting them. Less than 10% of oncologists report giving the survivorship care plan always or most of the time. And most oncology settings ask the patient to give their provider their survivorship care plan. Well, as you would probably guess, to ask somebody to bring something into their general practitioner's practice without an explanation, without, like knowing that the provider knew what they were supposed to be doing with this. And then to complicate matters, there were a lot of omissions and errors when the studies looked at them. The other thing that, people did at cancer centers was just focus on the most common cancers, because that was the easiest way to meet the Commission on Cancer's guidelines. And I hate to say, people are just trying to meet the guidelines, but that's kind of what happened. There wasn't time or finances in terms of infrastructure to support delivery. So someone has to populate them, and the doctor may not have time to do that, certainly. And the staffs, as we all know, medical staffs and cancer centers and everywhere are just really pressed for time. So there really was no way that this was going to get done. And to make it worse, there's no formal system to identify patients sending treatment. So unless the provider was like, oh, this person's coming up for end of care, you need to produce this for me so I can talk to my patient, it wasn't getting done. Some people even adopted sending it by mail. So that was kind of a problem, of course. So it wasn't given to the primary care provider. And then if the person goes to a different one, it doesn't transfer. So, and then it wasn't updated with new conditions. So it was just it was just a really sad situation going on there. Next slide. So there was some research on this before it was just hung up to dry by a group. And my colleague, Paul Jacobson, did this study that he published in a journal of clinical oncology. And what he showed is that over half of studies didn't even randomize. So when you look at whether something worked, you're going to give them something that you think will work versus nothing or usual care. Well, they didn't really do that. These were the studies that he selected to rate for quality. And even the randomized trials, like that look at, getting a survivorship plan or not, they were weak. And these are just different ways that we look at weakness, like a design or, were the providers blinded, which I think would be really hard to do. Were there a lot of dropouts? And so he rated them, and all of them were weak. I think there was one that was kind of medium, moderate. So he thought that, first of all, it's not just whether the person gets it, it's whether the survivorship care plan guides care and it improves symptom management and adherence to follow-up. So they didn't look at that. So that was a thing. Like most of them are focusing on satisfaction. Like, were you happy you got the survivorship care plan? But seriously, it's really supposed to guide care and make it so that the patient can take control of their care and manage their care. So, and most studies talk about early stage cancer, and there's so many other types of cancer, as you know. Next slide. So that was just a big debacle, and people were pretty mad about it in the survivorship care space. So we were all like, what in the heck? So you can't just legislate giving a plan unless the plan has some teeth to it and actually guides care. So there were some changes. So they issued some clarifications on the survivorship care plan. And, people said that they felt confident doing it, that they could do it. So what they ended up doing is keeping the survivorship care plan, and they changed it to more people getting it. So their response, which is kind of sad, I don't mean to make fun of anybody, but it was like, okay, well, this isn't working, but we'll just make you do it more. So that was not a good response. And they said, they clarified that it was just to cover patients who completed active therapy, that metastatic patients weren't covered by the standard. So what they did in response to low compliance was just make compliance higher. Next slide. But sadly, it didn't work. And I think it was just a really sad situation for survivorship, because our first effort at sort of addressing it just didn't work. It didn't work for obvious reasons, though, of course, without enough institutional support for it. And then some basic skills training, right, for the survivors on what they need to manage, what to expect, and how to facilitate their confidence in managing their survivorship care would be like super important. And then there was just nothing on psychosocial outcomes or unmet needs. So this is a problem too. And so we were hoping for a more cost-effective and patient-centered approach by stratifying risk, like who needs super long-term survivorship care, and what people could go back to their communities and their regular physician just work with them on what is needed, and maybe come in once a year to the cancer center. So using the focus for high-risk populations, so high symptom burden, lower income patients who do not have access to care after oncology treatment ends. And then there was the suggestion that we adopt more survivorship care plans tailored and evaluate implementation of the plans and select appropriate outcomes desired for what might matter to the patient. Next slide. So then that the new guidelines were issued, and the new guidelines, which I think I may be wrong, and it's just something will correct me, but I think it was 2019 or 18. And the new guidelines suggest that we have a survivorship program coordinator at each cancer center, and they develop a survivorship program team. There were physicians, advanced care providers, nurses, social workers, nutritionists, physical therapists, and allied health professionals involved. The outcome of this was that there was a list of services and programs offered on-site or by referral that address the needs of cancer survivors, and we would need to offer 3 services each year, and we would need to show that they are being used over time, and that we could add services when we achieve our aims with the first set of 3 services. So those are the guidelines that were adopted. So they no longer is their care plan needed, but really services relevant to the population and a team of people to treat those issues. Next slide. So at about the same time, there was a great deal of attention given to models of survivorship care. So what would be a better way to address survivorship needs than a care plan? So there's one approach that looks at risk stratification of levels of care needed with coordination with the primary care provider. Oncology settings devise ways to provide care for their burgeoning population of survivors. So they can't provide care to everyone. So what they were thinking of is risk stratification. So there was many, many models and taxonomies that were separated by care settings, like separate clinics, who's providing clinic, is it who's providing care, nurses, a shared care approach between the primary care provider and the oncologist, or transitioning to the primary care provider. There are some specialty care roles. So for example, you will have the survivorship clinic run by in some models, and I'll talk about those in a moment, they would be run only by the oncologist for one tumor type. So that's a separate clinic and specialty care. Or there would be an integrative clinic where there would be the oncologist who is more working across cancer types. And then there would be an APN there, advanced practice nurse, and maybe a nutritionist. So there would be on site for the clinics a person who handled other types of issues that survivors experience. And then the purpose, of course, is the purpose of this a transitional meeting to transition the person back to their primary care provider, or is this a long-term care model? Next slide. So the reason that we're trying to look at the delivery models is cost effectiveness, obviously. What speaks to large hospital systems, including WJ Barnabas Health Oncology Service Line, is what is most cost effective. It is estimated that 25% or more of oncologists spend their time doing follow-up care. And of course, delivering active care to newly diagnosed patients it delivers more money. So there's a huge reason why we want oncologists to move on to their next patients. The other is to improve quality, because if you're having all care delivered by the person's original oncologist for the next 25 years, there's no integration with their other care providers. And so let's say that they don't come but every 2 years, but they're not seeing their cardiologist, or they're not seeing for endocrine, like they develop diabetes. So it just ends up the longer term model doesn't really work when the person isn't really getting quality health care that could be provided by their primary care provider. So it's just a fragmented model, and it's really not going to work in any way for care quality. As we all know, everybody works better in teams in providing care rather than just one person doing it and one person doing something else. And the one person doesn't know what the other person is doing. And it really will improve patient-centeredness too, because it links survivors to the care that matches their needs. So there also then would be the opportunity to look at not just cardiovascular and diabetes risks and secondary cancers, but what else are these survivors wanting? So there's the questions: what care, who should deliver it, and where should it be delivered? Next slide. So there is a lot of considerations, and this is just a list of all the things that need to be taken into account when you're devising a survivorship care model. Next slide. The emerging consensus guidelines are coming out. They're recommended. So some cancer-specific post-treatment care recommendations that include a transition, but the U.S. has been slow to implement them. So there are consensus guidelines for survivorship. Unfortunately, I think the way that our healthcare system in the U.S. isn't just ideal for this transition care model. So there are better models in Canada and Australia where there's socialized medicine, where they do evidence-based guidelines for levels of care. For example, Ontario, Canada does direct transition to primary care provision for low cancer risk. So let's say stage 1, stage 1 or 0 breast cancer, no genetic issues, finished all active treatment, may or may not be on hormonal maintenance. So that's a patient that could go back with some guidelines and maybe, visits with their oncologist every year or so. But most of the models do 1 to 3 visits with an oncologist, and they transfer back to the primary care model. And then there's a shared care model for high-risk patients, high genetic risk patients that are a little bit later stage and might need more surveillance for secondary cancers or metastatic cancer. And so that's their model, and that works for them. Next slide. There's so many care models in the United States. So I'm going to go into this a little bit in a moment, because we did a special series on cancer survivorship models for the journal Cancer Survivorship. But there are just so many models. It's just a lot. So you can see an oncology specialist, a cancer-specific clinic, like a primary, clinic for breast cancer, a clinic for lung cancer, a general clinic, which is what we will have with our new survivorship leader. So she'll have a general clinic that's consultative to all cancers. And then, so she's going to do a general clinic. I don't know that she'll do a consultative model. What a consultative model is, just one-time visit to the survivorship person, but that's a problem because it's a care silo, meaning that they don't talk to the primary care person, and it's just a consult. And then just like issues an email, through an electronic medical record. Shared care is really what we want. We want shared care, and we want a transition. So the last two are really the preferred models for long-term care for most of our cancer survivors who are at low risk. Next slide, sorry. So what I did is I had interviewed cancer survivor programs across the country about 3 years ago. And what Larissa Nekledoff and I decided to do was to ask each of these survivorship programs to talk about the history of their survivorship center. We had 8 different centers. There's 4 here. We chose centers that both had been started many years ago, like the University of Pennsylvania, They got a grant from Lance Armstrong Foundation. St. Jude's is the longest and privately funded hospital that has a cohort of cancer survivors that are kids. So they're a high resource place. And then you have places that are a little bit lower resource, surprisingly, like Dana-Farber and Stanford. Next slide. So here's like the models, and I'm only going to show you 3 of them just because there were more differences than there were things in common. So University of Pennsylvania is an old program, and it has a ton of affiliative services associated with it. And it has a care provider who runs a clinic and conducts research and education. It was established, though, in 2001, so many, many years ago. What they talked about in their presentation about their program was that it started out with a lot of funding and then it didn't have any funding. So they're really struggling now to maintain the program. Next slide. Stanford has a clinical care delivery model that is disease specific with some subspecialty services as consultations. So they do run disease specific programs. I'm going to skip over the research and training, and they even have some partnerships with community. Stanford also reported not having sufficient funding for the survivorship care program. So while they might initially devote funds to a survivorship care provider, an oncologist and several nurses, that isn't maintained over time because it isn't part of the treatment infrastructure because it clearly probably doesn't make enough money. Next slide. Dana-Farber has a really strong survivorship model because they have a primary care provider, Larissa Nekludoff, who is a co-author. And so they really do provide across the board consults, a longitudinal model where they follow people long term. They have an extended disease program where they look at high risk patients. They do some interventions for BMI, and then they have some subspecialties. And then they have a bunch of special programs, which would be a great idea for a survivorship program led by a primary care physician who has a specialty in oncology. Next slide. So what you can see from all of this is that there's just so many different models, and we are really, really trying to arrive at a more coordinated care model where care is shared between the primary care provider and the survivor, so they don't get lost in the transition. Harkening back to 23 years ago, where we decided that we should really pay attention to people with cancer who are living longer with other multiple chronic conditions and really try to coordinate care. So the cancer is just one of the many chronic diseases that they have, and cancer is a chronic disease when you live long term. So we really we're hoping to get evidence that these primary care transition models are good for the majority of patients and cost effective. Next slide. And I'm running out of time, about 10 more minutes. So I'm going to talk about what we have and what we want. So we want to have shared models that incorporate primary care together with the oncology care. But what we have is mostly research models, looking at it and developing models of care. We're really not there yet. Next slide. And again, risk stratified care is what's needed. Let's move on just so that I can try and get to some of that. So at the end of all of this, we know that clinicians don't treat survivors as a distinct population or clinical category because they don't really know what specialized care they need, and they're not given the information about what they need to be talking to their patients about. And even if they had it, they don't feel supported in talking about cancer because that's something they refer out for. And so there's a lack of comfort and a lack of information, and there's not a lot of information they're given because it's not in the medical record. And they don't know what to evaluate for. Next slide. So again, there's the capacity to do it. There's a lack of awareness of survivorship needs. There's financial drivers that are causing huge problems in treatment of cancer survivors. It's communication issues, and most primary care practices are not in the category of advanced care practices, meaning they don't have someone on site, like for diabetes, who is a specialist. So most primary care practices even have a diabetes specialist that can treat and work with a complicated case. And that's just not the case for cancer. Next slide. So I'm just going to talk really quickly about what we do have in our toolbox for cancer survivors. Next slide. We have lifestyle interventions that have been shown to be efficacious. There's been many, many large clinical trials looking at exercise sessions for vigorous exercise, moderate to severe and aerobic exercise for breast cancer survivors that have shown effects on reducing body mass index and circulating biomarkers, things that are risk from the endocrine side. And so we do have effective treatments that focus on some of the risk factors for recurrence, physical activity, and weight. Most of these studies are focused on breast cancer survivors. There are fewer focusing on other types of cancer, but really every month there's more and more out there research-wise in this space. Next slide. Like I said, these are going more towards online interventions, which is great because then they can be linked with your activity, your steps. And so again, these are just Golden Leisure Time as an activity scale, just showing that people are exercising more, and it has a tracking tool, just like a Weight Watchers tool. Next slide. There's a huge literature on psychosocial interventions for survivors. That's dating back 30 years with many efficacious interventions. Next slide. I'm just going to talk really briefly about my work. So I work with women who have survived gynecological cancers and look at interventions to improve quality of life and reduce distress. Next slide. I've conducted a couple studies. This is just what I do in the intervention in terms of stress management, coping skills, communicating feelings and enhancing support, dealing with fears about recurrence, which are realistic for this population, sexuality, intimacy, and body issues, and just general skills. This is a 7-session with a phone booster intervention that has been moved to telehealth. Next slide. So now I have it currently on a website with me doing telehealth counseling sessions. But this is just the original face-to-face intervention, showing that my skills-based intervention outperformed a supportive therapy intervention and usual care. Next slide. So that study is now with the National Institute of Health looking at funding to look at the telehealth intervention with effects on post-traumatic stress disorder and different biological outcomes in gynecological patients. The next study that I'm doing is fostering surveillance and prevention of recurrence among melanoma survivors. Next slide. So as you probably know, most people with cancer, with melanoma cancer, actually do discover their own growth and bring it to their doctor or their dermatologist. But there's the formal recommendations are really for regular skin self-exam for survivors, just because most people do find a recurrence, and it does make skin self-exam effective if it's done in conjunction with physician's exam regularly. There's no guidelines on sun protection. Next slide. But unfortunately, melanoma survivors do engage in sun, they engage in lower levels of sun protection and are not as adherent with skin self-check. So this My Smart Skin is an intervention that we developed online to help people deal with doing skin self-exam in a more comprehensive way. Next slide. So keep clicking. Sorry, it's like 4. We showed in our original study that it did increase thorough skin self-exams. It did increase whether someone helped them with it, because you need someone to look at your back, whether they used a mirror and they used a body movement. These are all things that will help you to find things earlier. Next slide. So we're now doing it in an app. We've just finished the app and we're just going out to field to look at its effects. It's a really cool app. You can take and upload pictures of moles in it. It's really cool. Next slide. So the Facebook intervention trial is a study for young melanoma patients. As I've talked to you before, young adults. Population is increasing. Melanoma is one of the populations that's increasing in young people. Next slide. So what I did was focus on these survivors who have, it's a very common malignancy for them in young age range. They're at higher risk for second cancer, and it rises as they age because, they live longer. Obviously, they're diagnosed younger. Next slide. Why focus on families? Mostly because these are young people, and the way to get them working on their behavior is to focus on the family. Also because relatives of young onset patients and any person with melanoma is higher in their family members. Next slide. Not a lot's known about relatives of young onset survivors. This was a slide before I started the study. So, the engagement in skin self-check is low, with about 35% not doing it even in the past year, and engagement in sun protection is lower than it should be. It's actually about what it is in the general population, but it should be better in this population. Next slide. So next slide, what we did is we do a Facebook intervention for patients and their families, and they're enrolled in a group of about 20 to 25 families. So it's a young person with cancer and their siblings for the most part, and sometimes their parents. Next slide. The content, you can move on to the next slide. The slide is, the content is really about physician self-exam, engaging in sun protection, and what to look for in a skin self-check. Next slide. Next slide. Oh, you can go. So we're not done with the study. We have run 10 cohorts of groups. The other condition is a healthy lifestyle condition. So they're either randomized to get our intervention or something similar and engaging, but not on sun. The last slide, I'm going to just cover this. This is a study for oral cancer survivors, and it's a mobile responsive intervention. Next slide. And I just want to go to the conclusions after this. So the goal of this is to improve exactly what we were talking about, self-efficacy in managing their symptoms. So oral cancer survivors have dry mouth. They have trouble swallowing sometimes. They need to change their what they eat because of dry mouth. They're at risk for second cancers in their mouth. And there's just speech can be effective, hearing can be affected, swallowing can be affected by radiation. It's just an ablative cancer because, of course, it's in the mouth. So anything above, at the neck or above is going to be problematic for function. Next slide. So next slide. What I found is that they didn't engage in they didn't have much confidence in maintaining their self-care. So the intervention is being tested, and I'm giving them a comparative website that is just Springboard Beyond Cancers by the American Cancer Society. And then the other half is getting our intervention. We're at almost 600 patients where we will be wrapping up that in the prior study in the next 6 months. That was just to show you kind of what investigators do in this space in terms of survivorship intervention. So what's the challenges? Really, simply giving a treatment summary is not survivorship care. We have a lot of ideas about how long-term survivorship care could be provided. We know that sharing care with primary care providers will be our goal. We have little evidence that this care is being done, especially among those survivors that are seen only in primary care settings. If they go back, we're not sure what's happening with their survivorship-focused care. We know we can improve physical activity and reduce distress, but there's very little implementation of what I might find or others might find to be effective in cancer survivorship. And the reason is exactly what you just saw with survivorship care programs. They're not well funded, and there's just not a lot of interest after the patient finishes their care in really improving and maintaining health by cancer centers. There are known disparities, and I didn't talk to you about this, but there's huge disparities in care among rural cancer survivors and people in low SES areas. The main issue, of course, is that survivorship isn't a moneymaker, and large hospital-based systems don't want to support it. And primary care settings have potential if payment is bundled along with other chronic diseases. And so before I take questions, I just want to say that holds a lot of promise, because if cancer is treated like diabetes, there are clear outcomes, there are clear treatments, and it's bundled. The treatment is bundled. So the primary care provider would get an incentive for providing high standard survivorship care that would be delivered by a specialist in the office. Next slide. I think that's it. And I'm sorry, I don't know how many minutes I have left for questions.
No, that's
There were
fine.
some
Thank
questions.
you.
Could someone just read them maybe?
Sure, yeah, that's actually what I was going to do. Thank you, Dr. Manny. So we do have a few questions here. So the first one is, for survivors, how soon should they start screening for other cancers?
Yeah, so it depends on the type of cancer. So there are everybody should adhere to the general guidelines. So for example, every breast cancer survivor should be having colon cancer screening. Breast cancer survivors who smoke or have a history of smoking, I think the PAC years is now 20. I don't know if it's been lowered. Should be getting lung cancer screening. Obviously, all pap smears for women who are in that age range. Specialty follow-up care for surveillance depends very much on the type of cancer. So for example, women with gynecological cancer who have no evidence of disease and at high risk are screened every 6 months or less for the rest of their life. So it depends, of course. So they have a CA-125 blood test, and they will have a CAT scan of their, the lower abdomen. And so that is what's done for them. For melanoma, these patients are relatively low risk after the first couple of years. So they're seen every 6 months the first year, then they're seen less the second year. And then really, they're not coming in very much, I think every several years, and that could be transferred to the dermatologist. And then they just have to do things that everybody should be doing, like avoid the sun and do skin self-check. So it's very variable based on the type of cancer. And as cancer treatments get more and more tailored, it's just going to be more and more different. So for example, breast cancer survivors might be on a maintenance therapy for hormone ablation if they need to take it for 5 years. And now they're suggesting it's even higher. I forget what the guidelines are now, but they're longer term on maintenance therapies. So even the definition of survivorship is going to change, and it changes with immunotherapies as well. So you can have people on long-term immunosuppression for melanoma, but of course those patients are later stage now. Longer term, we're going to have more and more people in that category of maintenance therapy. So it's even going to be more important for us to pay attention what patients need to be seen for what. And so the screening is so dependent on what the cancer is. I hope I answered your question correctly. It's just so variable.
Yeah, no, that was great. Looks like we have another question in the chat. It says, what are the missing pieces or data to move us toward having the survivorship treatment bundled as in diabetes?
Yeah, so that's a political process and a policy process. And so generally, what needs to be done is to show that primary care delivered oncology care for low-risk populations results in better outcomes. There's an investigator here, Shauna Hudson, who has a study that I think just got funded looking at exactly that. So in order to change policy, we're going to have to show evidence to suggest that something is better. And then it becomes an advocacy survivorship thing. So then people like President Biden and Jill Biden, who's a very strong advocate of cancer survivorship. Jill Biden travels around for the Moonshot initiative. So these people have a lot of power. So once we have some evidence, then we can advocate. And then it's enforcing guidelines by cancer centers. So again, we can put whatever guidelines we want, but cancer centers need to put funds into this kind of delivery model, meaning doing a transition and care model, right? Where there's an APN or an advanced practice provider transitioning patients off of treatment. And so there's going to be hand in hand between research, the National Cancer Institute's advocacy efforts, taking it to the Hill, getting insurance coverage and bundling, and then really trying to get some guidelines the same as diabetes. So for diabetes, they show better outcomes with this model, but not everybody has one of those people in their practices. I mean, it really depends on the provider and how enriched the setting is. Again, the people that have more enriched settings get better care, but that's not everybody, as you know, and especially it's not low-income cancer survivors seen in the community in a rural setting. So it's a completely different problem.
All right, thank you. Here's another comments in the chat. If Maria, if you'd like to unmute yourself, or Katie, I know they're talking about challenges in the continuity of care, challenges for younger survivors. So feel free to unmute yourselves if you'd like to ask Dr. Manny any specific questions. But we also have a few other ones as well that popped up in the chat. Do you still have time, Dr. Manny?
Yeah.
Okay. Perfect. So this other one that we got was, how can we boost community confidence in shifting the mindset that survivorship starts after treatment?
I know, it's an excellent question. Thank you for asking that. So survivorship starts at the moment of diagnosis. I think if we took a broader view of it from the oncology side, so I don't think that even oncologists agree with this guideline. And so if it really does start with the care setting, I believe, which is referring to everybody as a survivor. Doctors refer to people as patients, and then they enter survivorship when they finish definitive treatment. But if you ask a lymphoma doctor, what he or she thinks survivorship starts, they're like, it starts at 5 years because they have survived 5 years. And it's only at that time period that I consider a person a survivor. Those kinds of models lead to limited transition to survivorship. By the time 5 years is over, the person hasn't changed their lifestyle. They haven't lost weight. All these things that they could be doing to foster their own health aren't being done. So it's a huge issue that I feel if cancer centers just thought of this as a continuous care, that we would be transitioning people with the tools they need. I don't know how it will change. I don't think the NCI changing the definition is going to fix everything. It's a much bigger issue, and it's especially a big issue if doctors themselves are saying, well, you're not a survivor until your cancer hasn't recurred in the first 5 years. Well, that's nice, but it's really, yes, they probably need to be providing more active surveillance. But if you defined it as survivorship from the start, then people wouldn't feel categorized and there'd be more continuity. Sort of chicken and egg, right? So it's like, well, if we're all survivors, then we're responsible for you, but there's no taking of responsibility. And I don't know, it's a bigger political issue than it probably ought to be. And it comes down to money, right? To what care reimbursement is for the oncologist. And sometimes oncologists like to see the people who are well. It's good news in their day. I mean, breast oncologists, everyone I know says that's the highlight of my day because I get to see someone who's happy.
Yeah. Oh, wonderful. And then we have one last question for you. So in a perfect world, Dr. Manny, what would survivorship care look like?
Yeah. So in a perfect world, I'll use CNJ as an example. In a perfect world, we would have a survivorship care leader. That survivorship care leader would only be designing survivorship programming for their cancer center. They would have specialty providers that work with them, paid for part of their time. For example, cardiology, nutrition, psychosocial care, fertility, managing speech and hearing and lymphedema. So there would be supportive care specialists. And then there would be hand in hand some patient-related outcomes that would be also given so that we would monitor whether we were improving outcomes. So that would be linked in, right, with the care. And then in addition, there would be a strong transitions program. So there'd be a risk stratification. So that person or persons that were working with the population would stratify the care. So you're an early stage breast cancer patient and, I'll see you once and twice, and then you'll get all these referrals, and then we will transition you through a shared care model back to your primary care provider. And we will not see you other than your yearly visit, like not like saying I'll see you, in a month or 2 months, but really taking a transitions approach. So it would be funded by the Cancer Institute because it's not going to make a ton of money. It does make money through referrals. I mean, referrals to nutrition, tobacco cessation. So in addition to, sort of the funds from like having those people that see the patients, see new patients, which is a cost savings, there would be a financial incentive for people to be seen and referred for better care. It's just more infrastructure and money. I think if I had a wish, there would be more infrastructure and funds available because it would be very, very helpful to have a stability in care. People develop great programs and then they lose funding. And then they say, oh, you should get a grant, but a grant can't support clinical care. It'd be like saying to oncologists, you need to get a grant to show this treatment is effective in order for me to give you the oncology care that you should be giving. It's a very twisted model.
And is there
sounding critical, but I am pretty critical.
and is there any push in having the psychosocial support as a vital component of survivorship?
Yes, actually, there is an emphasis on this. The one thing that is actually required is distress screening. So there's a distress thermometer that is used. Actually, that's during treatment as well. That's been implemented reasonably well. And there is, many cancer centers do have psychologists. We do not, but many cancer centers have a psychologist or two on staff. Social workers handle it here. I'd say of all the treatment effects, that's handled because people get a distress thermometer when they come in, even at survivorship. So they're supposed to be. and there's reasonable compliance with it. The issue, of course, with survivorship is the oncologist shouldn't be treating that. That should be really transferred back to the primary care physician and a psychiatrist or psychologist. You know what I'm saying? Like, I could see you once a year and give you a distress around. That's really not going to help you. And so for most of my studies, I'm calling people where, they're not getting care, they're depressed for my studies. And then it's like, I'm trying to handle it on a study, like where to refer them and what to do with them. So once they're in survivorship, they're not getting frequent assessments like they should. And that's a primary care doctor's job, as well as the patient paying attention and doing something about it.
Wonderful. Well, thank you, Dr. Manny. That looks like I know your time is valuable. And so if there are any other questions at the end of the presentation, we do have a new platform that we're using called Mighty Networks. If anybody else has any questions for Dr. Manny, please feel free to input them there. And then we can always reach out to Dr. Manny and, if you have time, perhaps give us those answers and we can share them with the community. But thank you again for that very informative presentation. We really appreciate it.
You're right. Thank you. I'm just reading the comments. Thanks everybody for
Sure.
attending. And I really appreciate your attention to this topic.
Thank you. All right, well, now we will transition towards our case study. But before that, I just wanted to give everybody a brief update on our community cares. If you've seen that, we're also transitioning to partnership with Project Echo, as you can see by our backgrounds. So I'm just going to share my screen to give everybody a little bit information on the new the Project Echo model. And can everybody see my screen? Perfect. Okay. So just a little bit of information.
Gabby, we see your notes. We see
Oh.
the presenter version.
That's not good. Better?
Yeah.
You guys can see my cheat sheet. All right. Well, Project Echo, just to give everybody a little bit of a background. So the Rutgers Cancer Institute actually became a Project Echo hub in 2021. And so this Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The ECHO model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right time and at the right place. And this is done by using technology to leverage scarce resources, sharing best practices to reduce disparities, applying case-based learning to master complexity, and evaluating and monitoring outcomes. So if you're looking for any more information about Project Echo, please visit their website, which is down there in the bottom in bold. And with that, we will transition over to our case study. I will actually hand it over to Lisa, who is here as well. Let me stop sharing.
Gabriella,
Am I still sharing?
can you pull up the screens on your?
Yes, absolutely. Do you want to do a quick introduction, Lisa, while I'm doing
Sure.
that for you as well?
So my name's Lisa McQuilkin. I run the Livestrong program at the YMCA for the Summit Area YMCA. I've been doing it for about 13 years. We run anywhere between 4 and 6 sessions a year and serve the communities inside and outside our service area. So sometimes we have people traveling quite a distance to get to the program because there isn't one close to them. Although the program is offered at WISE throughout the country. I think last time I saw the stats, there was something like 300 programs throughout the country being offered. It might have changed a little bit since COVID. Some of them didn't come back after COVID, but they are local within each community, and the foundation of the program is similar. So the details that I talk about my program should be similar to ones throughout the country. Gabriella, could you pull up the slides, or are you having trouble with it?
Yes, it is.
Whenever you're
Oh,
ready.
it's saying my screen sharing is paused. Let me see. I apologize. Looks like I'm showing you guys all my notes and it's not properly. Let me see. I'm going to stop sharing and I'll try it one more time, Lisa. Thank you for giving your introduction. I appreciate it. And it looks like, let's see. Share. There you go. Is it popping up?
There we go. Yeah, so the Live Strong program at the YMCA is a 12-week program. We meet twice a week. Times vary. Our branch offers a daytime program and a nighttime program because there are some survivors who are still working and need to be able to access the program in the evening. So we do offer both. Go ahead and flip to the next one. So the program focuses on rebuilding cardiovascular endurance, muscle strength, balance, and restoring range of motion. We work in a small group setting, so the group can be anywhere between 4 and 12 people. And we have trainers who are certified not only as trainers, but then specifically in working with people in cancer recovery. We work in a small group so that we have the ability to modify the program as needed for each participant because everybody comes in with their own set of issues. The space is specifically designed for physical activity, but it works as a default for these people to share their experiences and concerns. And many times the groups end up being a support system for each other. We've had people in the program who have not had the opportunity to talk to other people in a similar situation. And the benefit of the social aspect and the sharing is sometimes just as important as the physical aspect. We have the group that I'm going to talk about now that finished last fall. They still meet for lunch on a regular basis. And they come back to the Y and they bring their brown bag lunch and they sit and have lunch every couple of weeks, which is really great. Go ahead, the next one. So the last group that I'm going to talk about, we had 7 participants, 4 breast cancer, 1 brain cancer, 1 currently endometrial, previously breast cancer, and 1 follicular lymphoma. So we do see a wide variety of cancer types. The majority is usually breast cancer. It's usually about half of the people in the group are recovering from breast cancer, but we do see a lot of other varieties. And it is open to any type of cancer, and we do have some experience in working with the side effects of multiple issues. Go ahead to the next one, please. So the last group that we worked with, the age range was from 50 to 81. The program is open to anybody over the age of 18, and we have worked with people as young as 22 and 23, and we've worked with people as high as 86 and 87, I think is probably the oldest. There are always multiple side effects for each person coming in directly related to the cancer treatment, including lots of times osteoporosis, neuropathy, lymphedema, fatigue, range of motion, muscle stiffness, and then a general loss of conditioning because during treatment, they may not have been doing anything that was very active. And then in addition to the cancer issues, we have various other issues depending upon the ages that we're dealing with. So knee and shoulder and hip, AFib, diabetes, obesity. We've had people who are, while they're doing this, they're also trying to stop smoking. So there's some issues related with that. And then the amount of exercise that people are doing when they come to us ranges from nothing ever to lots of times there'll be light walking or maybe some yoga. So most of the times we're starting from a pretty low threshold from a physical activity point of view. Go ahead to the next one. Part of every program that we do so that we're able to collect data is we do pre and post assessments. We repeat the same set of assessments in the beginning and at the end. Pretty standard. We do the 6-minute walk, a 1-rep max upper body, 1-rep max lower body. We do a 60-second balance on one leg, and then we do upper body flexibility using the back scratch assessment. Go ahead to the next one. So depending upon restrictions that people may or may not have, not everybody is necessarily able to participate in each of the assessments. So you'll notice on some of the results, like participant 5 was only able to do 2 because they had a lot of issues going on and had restrictions based upon weights that they were able to use or hip issues for the walk. So we don't ever require anybody in the program to do anything that is going to cause pain or cause any issues. And if there is a doctor's restriction or recommendation on weight, for example, if somebody is dealing with lymphedema, their doctor may say you cannot lift more than 3 pounds. So we tailor what we do based upon what the doctor's restrictions and recommendations are. So if you take a look at the results, we generally see quite an improvement from the beginning to the end of the 12 weeks. Shocking sometimes. So for example, participant 1, they had a 52% increase on the lower body strength from the day that we started to the day that we ended. And, that flows through in a lot of the other. So they were not able to do the lower body 1 rep max, but they may relate findings like, I can walk up the stairs and I don't feel pain anymore. Or I am able to carry my groceries into the house and I'm not out of breath when I finish. So we have the evidence that's data-based, and then we have the evidence that's situational that they share. It's interesting, this group particularly, lots of times the flexibility is the thing that we struggle with the most, and this group had a really positive increase on flexibility. So 50% increase, 76% increase, 66% increase. And especially with breast cancer survivors, that's something that we try to work on because they are coming in being very tight from surgeries and from radiation. And through the 12 weeks, we're able to make a difference with the flexibility. So the results can be pretty impressive from the first week to the last week. And then the goal after the session is to give these people the tools to be able to continue with the physical activity that they started so that they don't lose the gains. And we actually have a really high rate in our branches of retention. I have a group of 3 people who work out together every week on Thursday nights from 10 years ago. So they were in a Livestrong program 10 years ago. And for 10 years, they meet every Thursday night. I have another couple groups from 3 years ago, 4 years ago, 5 years ago. So the program makes a pretty big impact on the people who participate. And we would like to see more people participate. There's also no fee for the program, which is really important. We find that a lot of people have financial instability coming out of a cancer diagnosis and treatment. And depending upon sort of what their situation is and where they are, joining a gym can be a barrier to them exercising. So there's no fee for the program. And then when the program is finished, we do offer scholarship opportunities for people to be able to continue to access the facilities after the fact if they need. So I think that was the last slide, right?
Yes, that was the last slide. Thank you, Lisa. Does anybody have any questions for her? Feel free to drop it in the chat, or if you want to be brave, please feel free to unmute yourself. I actually do have a question, Lisa.
Sure.
So like you were saying that these members will often come back, be recurrent. And is there a way that I guess we as a community can help kind of push for, the importance of physical exercise after, something like cancer survivorship? I feel like, it's, you go to your doctor or something like that, and they say, oh, you're doing well, you're doing much better, but they don't necessarily push for things like physical movement or healthy eating. Are those questions that we should be asking to providers, to oncologists, things like that?
Absolutely. So, our referral system comes through doctors and treatment centers. So we do have doctors who do focus on the need for physical activity, nutrition after cancer treatment. Um, we get a lot of people concerned about osteoporosis because the treatment has caused them to lose bone mass. And that seems to be a driver because there's a direct result. They can see a change and an improvement when they have a scan from not exercising to exercising and the difference that it makes. It's hard. Some people still don't feel good when they finish treatment. And the fact that they're not feeling good doesn't make them want to come exercise. So it's a little bit counterintuitive, but many times if they do start exercising, they actually do start to feel better. So the support from the medical field and from nurse navigators is really imperative. Like the part of the survivorship care to include the physical activity is really important. And we we are very grateful for the partnerships that we do have, but definitely encourage more.
Awesome. Any other questions for Lisa? I actually do have another question if nobody else wants to chime in. I'm sorry, you guys are probably very tired of hearing me speak. But I guess, Lisa, the question that I also proposed to, oh, actually there is one. Oh no, any seed partners want to talk about cancer thriving and surviving? I don't want to talk too much. If anybody would like to speak up, please let me know. If not, I do have more questions for Lisa as well. So I'll just give it a minute or so if anybody would like to speak. All right, well, Lisa, my question is the same that I proposed to Dr. Manny. I guess in a perfect world, what would the future of cancer survivorship look like to you?
Well, in a perfect world, I would like to see all of our programs full with a waiting list so that we have to add more. The benefits, because we're outside of the medical setting, we're able to see, more day-to-day changes and progress and moods of the people that we're working with, because we meet a couple times a week. We meet for 12 weeks going forward, and they might only go see the doctor every once a month or every 3 months or every 6 months. So the little changes that we see and the benefits that we see are really are so important to the people who are recovering and surviving. It means so much to them to feel good, to feel healthy. It's really, it's amazing to watch the progress of people from the beginning to the end of these programs. I wish more people were aware and took advantage of the offerings that are out there, not just through the Y, but through other places. There are other organizations that have similar programs that focus on helping survivors regain physical activity in a way that's safe and supported.
Absolutely. Thank you, Lisa. If there are no other questions, I know we're kind of running a little bit close to time. I will share my screen and we can finish up with the last few announcements. Thank you, Lisa. Can you guys see my slides? And hopefully this time not. Okay, perfect. So these were just our introduction slides. So we're just going to skip forward, everybody. So just wanted to give everybody a little bit of information about our patient navigation team. So at the Rutgers Cancer Institute of New Jersey, we are committed to meeting the cancer-related needs of communities across the state. And our patient navigation team is here to help guide you throughout the cancer continuum by assisting with healthcare access and coordination, focusing on patient-centered care and communication, and coordinating appropriate and timely screenings. So their information is up there on the screen. Please feel free to call them, shoot them an email. They're wonderful, and we'll get back to you, and they're able to kind of help you navigate, you know, through whatever medical or health issues you may be facing. And then just to kind of spring up on that, we do have the NJC program here in New Jersey, so New Jersey Cancer Education and Early Detection. And it's a program run by the New Jersey Department of Health. And this is in collaboration with the local agencies and healthcare systems. And the New Jersey program, the NJC program, provides education and outreach within the community about different types of cancer. They provide free screenings to those that are unemployed, underinsured, uninsured, or face barriers to getting the cancer screenings that they need. And the New Jersey C program currently provides screening for breast, prostate, cervical, and colorectal cancers. And it is actually offered in all 21 counties throughout our state. So there is their phone number and then the facility search there as well. So you can see where they are in your community and in your area. And that actually brings us to the end of today's session. So we thank you for being here today. We really appreciate your attendance. We would be very appreciative if you were to fill out a survey. This is actually a QR code that you can just scan with your cell phones. I know everybody usually has that right on hand. And I believe Evelyn, I apologize, will also drop it in the chat as well. So we would love your feedback. Please let us know what you think of the new format, if there's any topics or subjects that you're looking for in the next year. And we actually have a new platform that we're using as well. So it's called Mighty Networks. And so the materials or any resources from today's presentation will be made available there. You can register there, and Evelyn will also drop the link in the chat as well. So please join our community. We'll have a lot of fun stuff on there. And there's even a chat function so that everyone is able to kind of discuss things with one another and keep in contact. And last but not least, we do have our March topic. So it'll actually be on cancer in the environment, cancer risks, safe in your surroundings. If you haven't registered already, if you're just here for the first time, please register through the link, and we really hope to see you there. Again, thank you for joining us, especially for those who joined us from areas that were very, very early. We absolutely appreciate it, and we really hope to see you next time. Thank you, everybody.